Good evening, everyone, and thanks for joining us tonight on this very special day, World Keratoconus Day. And my name is Dr. Bill Tullo, Medical Director here at OCULUS, and welcome to tonight's clinical webcast called Keratoconus Update, Ask the Experts. And speaking of asking the experts, you're going to have a text box you can go to on your webinar screen, enter questions at any time. We've put some time aside at the end that we can answer your questions. If we get too many questions and we can't complete them all, we'll answer them via email at the completion of the webcast. I'm really excited tonight to have our special speakers tonight, are Dr. Andrew Morgenstern and Dr. Clark Chang. Andy Morgenstern is an optometrist at Walter Reed National Military Medical Center in Bethesda, Maryland, the director of the American Optometric Association Evidence-Based Optometry Committee, and the current president of the International Keratoconus Academy of Eye Care Professionals. Dr. Morgenstern has no financial interest in the products discussed in this presentation. The information discussed is from the public domain and is not the opinion of the U.S. government. Dr. Clark Chang is Director of Specialty Contact Lenses in the Cornea Department at Wills Eye Hospital in Philadelphia. He's the host of the popular podcast, The Chang Reaction, with over a decade of research experiences in corneal crosslinking and other advanced corneal treatments. He was nominated as a top doctor in 2020 by the National Keratoconus Foundation, and in 2020 as well, he was the year's recipient for the AOA for the Luminary Award for Distinguished Practice. I also want to say a word about our third presenter who unfortunately can't make it tonight and is under the weather, Dr. John Gellis. I look forward to having him at a future presentation as we continue to do these webinars. And again, I want to thank everyone for attending tonight. So without further ado, I'm going to introduce our first speaker, Dr. Andy Morgenstern. Andy, it's all yours. Take it away.
Great. All right. Hi, guys. How are you doing? Bill, I want to say thank you very much for having me present here tonight. I want to say a hearty hello to my great friend, Clark Chang, who I think everybody here is going to learn a lot of information from. And I also want to thank OCULUS for putting this together. You know, OCULUS supports a lot of medical education in our profession in optometry and has always been great partners with optometry. And I'll be brutally honest, and like I said, I have no financial benefit to any of this stuff. I use the OCULUS Pentacam, which I'm going to be talking about here every day, and for these keratoconus patients, and I definitely think it's the best device for what I use it for on the market right now. Currently I'm the president of the International Keratoconus Academy of Eye Care Professionals. We are a not-for-profit educational society. Next slide. And you can see us here, and then right here there's a great picture of me, Clark, Barry Iden, and Bill Tullo, and you can see some of our other executive board members over here. We are Oculus agnostic, I'd like to call it. So we don't care if we work with optometrists or ophthalmologists. It's all about the eyes and the cornea. We've got a great executive board, and what our job is that we've kind of made the obligation to ourselves is to increase the level of education in optometry and ophthalmology for both doctors and patient on the topic of keratoconus. And so we're really happy to bring this information to you today. I do want to say before we get started, if anybody's interested, it's free to become a member. We have a ton of great information to share with everybody if you want to help up your game. And the website is keratoconusacademy.com, keratoconusacademy.com. So this is me. I think you heard my disclosures already. We can go to the next slide. And so the first question I want to start out with before Clark gets into the real meat and potatoes is to discuss prevalence and incidence. And for those of you who don't remember what prevalence and incidence is the total number of cases, and the incidence is the number of new cases every year. And so the question of what's the prevalence of the disease of keratoconus? And I want to frame it like this. When I do a lot of evidence-based work and write these guidelines for the American Optometric Association. And the reason why understanding prevalence and incidence of a disease is so important is because it should change, it should affect your clinical practice. You know, if we know that 1 out of every 3 people, and I'm just grabbing a number out of the sky, 1 out of every 3 people has glaucoma, and they don't. But if they did, if 30% of all people had glaucoma that walked into your office, you would know to be really sensitive to be looking for glaucoma in patients because it's such a common disease. Same thing with diabetes and diabetic retinopathy. And we can obviously apply this to keratoconus. And why is that important? Well, the reason why it's important is because when we were all in school, we learned that the certain prevalence and incidence of the disease of keratoconus. But we also learned that the disease of keratoconus really manifested itself in the second to third decade of life. And the reason why Oculus is putting this presentation on is because they have this device called the Pentacam that can look at the backside of the cornea, the posterior aspect of the cornea, to see if we can see the earliest changes associated with the disease of keratoconus. Well, why is that important? The reason why that's important is because we have a procedure called corneal crosslinking that can actually halt or slow down the progression of the disease and prevent further loss of vision. And why is that important? Well, because we want to identify these patients as early as possible. The earlier we identify them, the earlier we can treat them, and the more vision we can save. Well, one of the things that we learned over time, especially in looking at people in the refractive surgery centers over the last 20 years, we found that keratoconus is not limited to the second to third decade of life. In fact, there are many, many children, pediatric patients, that develop keratoconus. Bill and Clark and I and the Oculus folks, we were joking on the call before, and we were saying, nobody is born with keratoconus. Everybody develops the disease. There's no patients, no individuals come out of the womb with a keratoconic eye. And so what we have to do is identify when that change starts to happen. The other thing you have to realize is that just because you examine the patient at year 1 doesn't necessarily mean they're going to have the disease then, but they can have it at year 3. So not only checking it once, but checking it at every interval is really important. So one of the things that we did was a study. We'll get into it in a second. So I want to show this over here. Clark, I think you actually shared this image with me a long time ago. This is an image of the epidemiologic study of keratoconus. Everybody knows that number of 1 in 2,000 of the prevalence of the disease of keratoconus. Well, this is the journal that it came from. And if you look at the date in the top right corner, it took place in March 1986 was when this was produced. And so one of the things you have to realize is that 1986, for those of you who have been around long enough, realize that actually predates the topographer. So all of these patients were actually identified as having keratoconus with a retinoscope looking for scissors motion. That was the only device that they used at the time for this, and maybe a keratometer as well, but the primary device was a retinoscope. And so here you can see, is this really rare? You can see this paper from Dr. Hafezi, who's a great keratoconus specialist overseas. And this is where the most used prevalence of keratoconus is 1 in 2,000, which defines the disease. More recent studies suggest that the prevalence is significantly higher than 1 in 2,000. And we know that to be the case. So here's some literature from 2 of the best cross-linking people in the business, Dr. Hafezi and Dr. Hafezi from the ELSA Institute, who you will see in the future because they're developing a slit lamp mounted cross-linking device. And I think we'll see that over here in the States in the near future. And you can see that last sentence, the last line, is that keratoconus is now a not so rare disease. We estimate that the prevalence of the disease is 1 in 500 to 1 in 750. So that means if you have, 10,000 patients coming into your clinic a year, or maybe a little bit less, you better not only have 2 keratoconic patients as diagnosed. They're coming through your front door. You're just not identifying them because you remember they can be at varying stages of the disease as well. And I think this number in red over here, I think it's really important to remember 1 in 500 to 1 in 750 individuals have this disease of keratoconus. And so this, we started to look at, holy cow, what is the prevalence of the disease of keratoconus in the pediatric population? Because that's really important to understand, because if we can identify them as kids, well, and if we figure out what the prevalence of the disease is in the pediatric population, we can know how to screen them and how to perform our test appropriately. The only study that can be found, there are no studies in the United States establishing the pediatric prevalence of keratoconus. There was one paper, as you can see here, in Riyadh, Saudi Arabia, that it looked at, but that is a very limited population, and it's not terribly racially diverse, and it was a limited study, and it wasn't really a good number. One of the things that we actually set out to do, we wanted to establish, as the International Keratoconus Academy of Eye Care Professionals, was establish the prevalence and incidence of the pediatric keratoconus in the United States, because we need to know how many of our kids in this country have the disease, because that will change the way we look at pediatric patients. Clark and I and Bill always say, all of us out there see kids when we see patients. All of us, because our state probably tells us we have to, perform a Goldman or an NCT on a kid to find out what their intraocular pressure is. But the reality is, and I'm not saying not to check pressures in kids, I'm saying you still have to do it, but if you really think about it, how many times over the course of your career have you diagnosed a case of pediatric glaucoma in an otherwise healthy kid? And the answer is, it is incredibly rare. Now, think about the prevalence and incidence of the disease of keratoconus. It's much higher than what pediatric glaucoma is. We're doing all these pressure checks on these kids, but we are not checking we're not really checking corneas on kids unless we're really prescribing them with contact lenses. And so I think it's really important that we start to address that. So here's what we know. We know the prevalence is not 1 in 2,000. We know cross-linking is an FDA-approved method to halt the disease. We know the shine fluke camera of the OCULUS Pentacam, and there's other devices with a shine fluke camera as well, can detect keratoconus earlier than any other device. We know that we need a broad screening of pediatric corneas to identify those positive for the disease earlier, and with the intervention of cross-linking and scleral contacts, we can save vision. Children deserve a screening and treatment if necessary, and prevalence and incidence data is necessary to increase the awareness and change decades of old comprehensive eye examination minimum testing. So we started our study in 2017, and what we wanted to obviously do, we want to establish the prevalence and incidence of keratoconus. We had a no child left behind keratoconus policy. That means if we identified a kid with keratoconus that was progressive and they qualified for cross-linking and contact lenses, we would get them their cross-linking and fit them with medical contact lenses with a referral for follow-up. At this center, children who failed public health school screenings were referred for comprehensive eye examinations, and we did Pentacams on as many kids as possible. And so we have a prospective cross-sectional observational single-center study with data collected on ages 5 to 18 and/or kindergarten up to grade 12 in the Chicago public school system. We ran this through the Illinois College of Optometry as well. These are the testing points that we did on all of these kids, and we ended up with results. And the conclusion, this is just looking at these at-risk kids in the Black and Latinx population from our school-based clinic over here. This is a poster that we just presented last week at the Academy of Ophthalmology, and you can see the conclusion that screening for keratoconus in the pediatric population is important, as the younger onset of keratoconus, the poorer and faster prognosis, the increased likelihood of needing a penetrating keratoplasty, and a higher risk of future PK rejection. The study presents the normative data on several Pentacam indices. The results of the study can provide aid in the detection and diagnosis of children. Long story short, what I want to tell you here is that we identified plenty of kids. You can see the data in the results section. 2133 subjects that were screened. We looked at right eye data. Half the subjects male, half the subjects female, and the study focused on 2 minority groups, and we had quite a statistically significant population of patients that I identified as having keratoconus. So what I want to let you know here, and the take-home message, what you need to remember when you, go away from this presentation, go back to your clinic in the morning, you need to evaluate kids for keratoconus. Keratoconus is more prevalent than you think it is, and we need to have a detection and we need to have a solution. And this is the data from the study over here. This is the age range. The mean age was about 10 to 12 years old. Last thing I want to talk to you about here is how keratoconus can change in a given population. So I work at Walter Reed. This is all publicly available information. You can get this online through MSMR, which is a journal, Medical Surveillance Monthly Report. This is the January 2020, volume 27, number 1. We took a look at the incidence and prevalence of idiopathic corneal ectasias in the active component, which means active service members from 2001 to 2018. And these are all patients who are in the military, which is to say that they did not have keratoconus when they joined the military. This was endorsed by the Tri-Service Military Refractive Surgery Safety and Standards Symposium. Tri-Service meaning Army, Air Force, and Navy. And we published this in our journal, Front Lines of Eye Care. And what you can see here, so this is actually real data of real cases of the military. And the one thing that you can see, if you look at the bar chart on the left, the number of prevalent cases, the prevalent cases and lifetime annual prevalence of idiopathic corneal ectasias. That means they did not have LASIK. This is keratoconus only. For the active U.S. Armed Forces 2001 to 2018, and you can see those number of cases per 100,000 people in years increased from 2001 to 2018. Yes, our technology is getting better, but we're starting to see this disease more and more and more as we're starting to recognize it more. And here's a breakdown in the U.S. Armed Forces 2001 to 2018, broken down by age block, by branch of service, by rank, by military occupation. And the one thing that you can see, if you want to look at this, is really important to show that, just remember that the military, the government, we don't charge anything for our exams. This is straight up information. We want to know, can they see, can they not see? And so the total number of cases over 20 years, there were over 10,000 cases of keratoconus that was identified in a population of people that were known to not have the disease when they joined the military. That's to say that this condition can pop up on you at any point in time. And I think that's really important to remember, is that just because you find that your patient doesn't have keratoconus once, doesn't mean you can't not, that means that you still have to check them when they come back for other visits. And the things to look for, and I'm sure Clark will get into it, is decrease in best corrected vision, increased glare and halo, increased amount of astigmatism, and then obviously performing the testing with the right device. My personal preference, and probably all of my colleagues in the keratoconus world, being the OCULUS Pentacam. All right, well, with that, I had a great time chatting with you. I wanted to give Clark, I know he's got some great information here. I wanted to give him enough time to talk. So Clark, I'm going to turn it over to you. And Bill, thank you very much. And I really want to thank the Oculus team on the back end. There's a lot of people working behind the curtain on this one. And I just want to say thanks to all you folks as well. Dr. Chang, take it away.
Thank you, Andy. Okay, so I do want to just quickly mention that my disclosure, employment-wise, does include both Will's Eye as well as being on the medical affairs of Glaukos. So that's since Andy set us up so well, let's get into some of the tools that we're able to use to diagnose keratoconus, as Andy has highlighted very well in terms of the importance of being able to diagnose patients. And in 2015, there was a Delphi panel style consensus paper that had included ophthalmologists from different cornea society globally, and that this is their conclusion of the mandatory findings to be able to document in order to diagnose keratoconus. And you'll notice that anterior curvature, which is what we normally rely on in terms of using keratometry or placido disc projection type of topographer, really, that's not the data that is mandatory to diagnose keratoconus. Instead, they're looking at thickness distribution, posterior curvature, as well as corneal thinning. So, and also a question that I know that we all get asked a lot is whether or not we could use the apical thickness or the thinnest point of cornea as a sole risk factor or clinical factor to diagnose keratoconus. And from the same paper that I just quoted you from 2015, it was agreed upon that as a single factor, it was the least reliable indicator. And therefore, it is difficult to use that to diagnose keratoconus simply because a patient, if you think about it, while central thickness may be affected more early on, whether or not pathology is really present in the peripheral cornea, that still may be debatable, but the peripheral thickness, therefore, we majority of times think that it's likely going to stay about the same as virgin cornea. So the distribution of that ratio between central, mid-peripheral, and peripheral cornea, that distribution is more important than just a single point of thickness. And so that is the reason why prior to OCULUS Pentacam give us all these different metrics that we're going to get into, having taken care of patients in a refractive center, I used to do these manually, 4-map comparison or 2-map comparison, pending how many data visits I have on the patient, in order to diagnose whether or not their visual complaint is truly stemming from an ectatic disease process, or whether or not it's just maybe more dryness issue or cataract issue pending their age. So it was very helpful at that time. However, as more tools became available from the brilliance of the engineers at Oculus, we are getting spoiled with regard to having other tools such as BAD, which is Bell and Ambrosio display. And so what that does is basically saying, instead of, again, moving away from a single data point of the apex, right? So looking at actually a 3mm zone surrounding the thinnest point, so that we're not looking at only one single point. And then from there, looking at these values of what happens to, from there, being able to kind of exclude the central point of that within that 3mm surrounding the thickness portion. Because if you could kind of mentally imagine if the patient has keratoconus, the most steep portion likely is near coincident at where the thinnest part of the cornea is. And so that's going to overall artificially kind of inflate the steepness of the curvature average that we're usually capturing. So either looking at the area outside or only looking within that area, pending what you're looking for, can really help you rule out or rule in ectasia. And this BAD display also look at the distribution, look at those two curves that I told you about in terms of looking at the ratio of the central corneal thickness versus the peripheral thickness, that sort of slope, that progression. It then gives us a sense of whether or not somebody could maybe be 500 something micron, but really actually have an ectatic disease that's happening. And it has a lot of other useful clinical metrics that we don't really, in the interest of time, may not be able to get into, but don't worry, they have Oculus has a whole library on different tools or how to interpret BAD, so you're pretty safe there. Or we can get into a Q&A panel a little bit later if you do want to explore how else to best use BAD. They recently have this ABCD display that is very useful in my mind in terms of the monitoring for progression, because what do you do after diagnosing the patient using your whatever tool you like of what I just described? The question then usually becomes, well, what do I do and how do I monitor for progression? So I find this ABCD display to be very helpful, Nick. The next slide refers to the fact that every one of us are very familiar with the sort of classic keratoconus classification scheme called Amsler-Krumich, and or the AK scale. So why do we need a new progression scale called ABCD? Well, partially it's because if you look at the AK scale, it really mainly just rely on it relies on the thickness of the cornea, refractive power, which we know are very variable in keratoconus patients, and then some sort of keratometry value. So they're mostly really anterior representation of keratoconus. It doesn't really allow for, remember I just showed you that posterior data is very important from the consensus paper panel with their collective agreement in terms of how important that is in diagnosing keratoconus patients. So AK scale completely misses that. Also doesn't take into account somebody's best corrective vision. So if patient has subjective visual complaint, you're not really seeing a trend, at least not as easily seen using a software analysis. So I think for that, it's very important to be able to look at different metrics, and including posterior cornea, to then be able to help us diagnose keratoconus patients, but after and using ABCD and other tools, and then be able to monitor progression using the ABCD scale that I just talked about. And in terms of, so just kind of basically what I had talked about in terms of what the difference is in BAD, which is more useful in diagnosing something as being abnormal on the cornea, whereas Bell and ABCD progression display is really designed specifically to allow you to follow progression of the disease or the changes after a specific treatment, such as corneal crosslinking. Let's take a look at an illustration to help you out. So if you look at this ABCD display, now this is the old display, but it's very helpful, whereas we click through, you'll see that A stands for, please click. So A stands for anterior curvature, continue to click. B stands for posterior or back, continue to click. C stands for thinnest pachymetry, and D will stand for best corrected distance vision, your DVA. And then as we continue to click, you'll see that it sets up different color bars for baseline scan, from going to left to right, and the right hand side being the newest scan if you go to the next click. And so that it's visually very easily accessible. It also gives you two different type of one-sided confidence interval to allow you access to two different normative database, one of normal cornea, one of keratoconus cornea, to allow you to be able to follow different type of patients to see if there's any type of progression. And that's important because we know that irregular cornea is going to have a little bit more noise or variability in their for going from exam to exam. So it takes a much more changes on their cornea for you to have the same confidence level as a regular cornea to say, something is getting worse, something is changing. And that's why it's important to have this two different data set of normative database. And if we continue to click through, you'll see that then you could also adjust when the treatment day is to reset your baseline if you wanted to use your treatment and anything after that to compare prior to a pre-op situation, again, such as cross-linking, which is very useful. And the new display kind of make it horizontal so that it's a little easier to visually see quantitatively the type of change or the amount of change. And you still otherwise see basically very similar data being displayed. And as we click through the series, you'll see basically all the information are still there, where you can select the exams you want to compare. You can select either both eyes or just look at one eye at any given time. You could select which one you want to use as your baseline or reset the baseline if a treatment has been done. I really like this one on the additional information chart. As you can see, the other metrics like the ISV, IHD, IHV, that can be very important, and I'm going to come back to talk about that. But I just want you to know, and we can continue to click through, I just want you to know that all the values, if you're used to looking at ABCD display, they're still there, just at a different place on the new display that's more horizontally oriented. And you could set different the baselines, and as you could see, the arrows are kind of comparing for you. Keep clicking, please. Great. And you could also, I sometimes find the only thing that I thought was very brilliant is that sometimes I find it there's too many colors, right? You have the green confidence interval for 80% and 95% for normal cornea, and you have the red confidence interval. So you could turn that off. If somebody is more like a form frust, you're not quite sure, just funny looking cornea, maybe you don't want to look at the confidence interval of a keratoconus database, you can click and actually turn the red flags off, or the opposite, where you can click and turn off the green flags. So let's look at an example, which I think would be more clearly, I would provide more clarification. So this patient, if you would have looked at the topography map, the right eye would have been a little more suspicious than the left. And so now that we have 3 exams, we can now compare whether or not patient has been changing. So if you could click through for me again. and continue to click. So we're if we only look at the A field, which is the anterior data, you could see that if we select whatever exam you want to use as your baseline and next click, you'll see that the difference between the yellow and the green, which is 2 years apart, 2012 to 2014, that there is some steepening of the anterior portion, but not nearly quite to the 95% of the normal cornea normative database. So definitely nowhere near progression for a keratoconus cornea if this was a keratoconus patient. So that means that likely, again, you could switch off the green flag if you didn't want to look at that. But that means that it's unlikely that this patient, at least from the anterior radius of curvature perspective, that this person is likely not progressing. However, what I think it's possible, not knowing the complete history of the patient, this could be a possibly contact lens influence, right? So knowing that there's some change if this were a more normal, sort of funny looking cornea, but normal cornea, and yet there's almost 90%, almost a 95% confidence interval of change on the normal side, I would say, okay, I'm not going to let this patient go for a whole year. But probably, maybe, then I'll start thinking maybe I'll have the patient back in, depending on the age and the risk level, 3 months, 4 months, 6 months, and then maybe try to think whether or not it's possibly contact lens influence, right? A lot of us think, oh, if the patient's seeing well with a scleral lens, then keratoconus on a keratoconus patient, then it's probably not changing. But things could be changing even though they're maintaining their best visual acuity. So let's look at the left eye of this patient. If we click through, very similarly, even though the left eye is the eye on the topography map that looks more normal, if we look at the B field, this time for posterior radius, you'll see that the changes actually exceeds that of a keratoconus, 95% confidence interval of a keratoconus database. So that means that there's sufficient change here now, although only in one field, which is just a B. A doesn't kind of meet the 95% and C and D may not. So again, do you now, this may give you enough value to go by to say, I want to refer this to a corneal specialist to see if they now do a consultation and then continue to watch. Or if you know your surgeon well enough, you may be able to kind of directly communicate with the surgeon and say, hey, what should I do at this moment? So that's some ways of using the ABCD and how I find it to be very helpful. If we go to the next slide. So a summary, if you actually click both eyes, you could then actually be able to see both eyes at the same time. My preference is look at the one eye just because I could see longer. I could see distinctively more the disparity between the changes between different lines, but you could also look at both eyes at the same time. And then again, with the posterior progression on the surface of the left eye, that obviously raises suspicion. And think about the fact that if we're only using topography, this would have been missed. And as we click through, you'll see that, again, the red arrows will come on to show you what I'm talking about with the left eye having enough change and actually corresponding to some of these indices that I pointed out to you before, where 2012 exam, and one more click, you'll see that Kmax was still only 46.5. And then if you click 2 more times, you'll see that the next time that there is enough change in the A where the Kmax had gone up to 47.1, so it's almost 0.6 diopter flattening. And some of the other metrics such as IHD has gotten worse as well. So again, ways of kind of trying to catch patient as early as possible rather than waiting for the fact that they have Munson sign on their cornea, on your slit lamp. That's oftentimes a little too late to be intervening. Not that there's no value in intervening at any stage of a keratoconus patient's lifetime, but they would have lost a lot of quality of life. And now imagine if that person is related to you as your family member or maybe your child. I think that you would agree with me that we would want to help them as soon as possible. So what does that mean? Let's look at the next section, which is a little bit more updates on corneal cross-linking in US. So if we go to the next slide, just like any medical procedure, we want a fair and balanced discussion with our patients, a risk and analysis. So if there's any side effects, that of course I encourage you to report to the to FDA and the appropriate authority. Let's go to the next slide. So I think many of you already know the mechanism of cross-linking, and that is, at least as it's approved right now in FDA approved right now in in United States, removal of the epithelium, allowing diffusion of the riboflavin and also UV light and also oxygen, combining all the ingredients, allowing free radical to form, and therefore perpetuating the polymerization photochemical reaction that creates a new covalent bond that stiffens your corneal tissue. So I really want to do a throwback and give credit to the dentists who should remain unnamed. I still don't know what the name of the dentist to this day who inspired Dr. Theo Seiler in Germany to start looking into corneal cross-linking for cornea. Way to go, Dr. Dentist. This then eventually led to our phase 3 study in the United States, because obviously FDA required our own study within the United States involving our own population to make sure that the results are repeatable and reliable, and we should practice with evidence. So nothing wrong with that. And the trial, the phase 3 trial, included the number of patients that I'm showing you here, and using Kmax mostly via Pentacam as the primary endpoint for the success of treatment in terms of efficacy. So usually I get, this is a junction where I get questions. If it were an open mic lecture type of event, well, then how do you know when exactly, what kind of, if I don't have ABCD display, for example, how do I know how much change counts as progression? So some of the main criteria used in the phase 3 pivotal study in US and included in many other studies, we can argue about that these may be very conservative values, but at least it gives us a standard, and that is using keratometry value, typically Kmax of 1 diopter changes or more within a certain period of time. In the study, we chose 24 months. There are plenty of other studies that are within 24 months, meaning if you have change within 3 months, that still qualify as change. You don't have to wait for 2 years to prove that patient has gotten steadily worse. So within 24 months, some study use within 18, some study use within 12, some even start use within 6, pending the population they're working with. But typically looking at the Kmax change or keratometry change of greater than 1 diopter, or your refractive astigmatism change of 1 diopter or greater, which then obviously gives you the half a diopter spherical equivalence in your manifest refraction. I find the last one to be hard to use because a lot of times our patients are not in corneal GP, so it's difficult to use the back optical zone radius. But I think the first 3 criteria is a little easier for us to apply. Let's look at some of the efficacy analysis or what happened in the study. So this was set as a 1-year outcome study, and patients, as you can see, who were in the orange bar are the patients who were cross-linked, and blue bar are the eyes or the patients who were not provided the cross-linking treatment. And of course, many of them were allowed to cross over at some point because you cannot withhold treatment that has value to patients for longer than a certain period of time. So you can see that the orange bar, those who were treated, their Kmax continued to decrease, and the eyes that were not treated, in the blue bar, they continued to steepen, showing you the efficacy of cross-linking from the phase 3 trial. Next slide. So then what actually got approved is the Epi-off corneal cross-linking, where once we have sufficient riboflavin saturation in the cornea, we go to step number 4, where it was recommended, although not absolutely mandatory by FDA, but it was recommended to maintain that 400 micron in the thinnest point in the cornea prior to irradiating with UV for 30 minutes. And then here is another junction where I usually get the question of why does the 400 micron means that if I have a patient who's 395 before I refer, that there's no point for me to refer. The 400 micron, we need to keep in mind, is be it again, conservative, or we could argue that that may be a very conservative number, because there's some new studies showing that the diffusion rate or the diffusion coefficient of the riboflavin may be overestimated, and therefore we thought we needed 400 micron to maintain some safety threshold for the endothelium, but maybe we don't really need that. However, we need to respect what's approved within US. So if you look at this poster that was presented in the Academy of Optometry last week, it showed that in this single center clinic, where they actually were able to use hypotonic riboflavin, like they did in phase 3 study, but proving that you can get on average about 75, 76 micron of swelling, and even up to 161. And therefore that supports the fact that you could actually enroll patient at about 300 at baseline if you look at the 161 swelling, which is exactly what the phase 3 study did. They did enroll patient as thin as 300, planning to use hypotonic solution to cause intraoperative swelling prior to treatment with UVA. So therefore, you don't need the 400 micron preoperatively, nor do you need patient to be older than a specific age, because that's another question that I always get, which is, oh, my patient's way too young for this type of procedure. They won't be able to stand it. So at Wills Eye Hospital, we again did a poster of our pediatric patients, that being age 17 and under, and they all tolerated the treatment really well without the need for general anesthesia. And without any complication that was observed, that was unexpected, and observed as month 6 or month 12. So proving to you that you could have young patients going through this procedure with no issue. Next slide. But again, want to maintain fair and balance. So these are some of of course, we should always discuss risk and benefit with patients, but understand the majority of the adverse events. And that is to say, in a clinical study, you have to record everything that is unexpected or theoretically correlated to your treatment. Whether it really is or not, you have to report it. But regardless, majority of them resolve within the first month, and certainly the 1 to 2% that may go long term does not seem to affect most patients. And one of the things, next slide, that I usually get my colleagues asking is, what about haze? Isn't that concerning? So using the densitometer on a Pentacam, we can show that the haze is self-resolving without any therapeutic intervention in majority of the cases, and we do therefore think that having some haze changes may actually show that something is happening. So it could actually be a good thing. And another recent publication that was released last year shows exactly what we have known all along, and that is, but epidemiology study is needed. So in this health economic publication, they found that yes, applying corneal cross-linking does reduce the rate of corneal transplant in a microstimulation model, and that most patients spend almost 3 decades fewer years in the advanced stage of disease if we refer them in a timely manner. And also that I think what then is often underestimated is that we as physicians tend to force patients to choose. It used to be we force them to choose between contact lenses and corneal transplant. Now it's almost as if we're forcing them to choose between contact lenses and stabilization with cross-linking. And to be honest, I think it's very underestimated that the combination synergy of 2 approaches provided to the patient, that is to say, stabilize them so they potentially mentally have a better outlook for their quality of life and their vision. Then, because they're stable, we don't have to spend too much time refitting them or worry about it. So the longevity of our optical devices that we're prescribing to these patients as medical devices can actually have much longer period of time where it's effective. So I think that combination is what a lot of times we're missing. The question may be, well, then when do I start contact lens fitting evaluation for my patients? In my personal opinion, and the patients that I've seen, including those that I collected data from pre-FDA trials, I typically see them as they're somewhere between 3 to 4 weeks pending their healing, right? So if the post-operative course is very typical, and that they heal within first 5 to 7 days with their epithelium. I make them wait for another week or two before I evaluate their contact lenses. And thereafter, in a study, months, 3 months, 6 months, 12, where they would either be followed by me or by the cornea specialist. And so with contact lenses, obviously, if you feel like, hey, I don't really, these patients are more complicated, I wish there is an easier way to get customized contact lenses or contact lens customization calculation without always, being burden on you, then you have the CSP module on the OCULUS Pentacam that could help you out. Next slide. And so you may ask me, well, you did a very good job in presenting your, the 1 year data that you were involved in, but is cross-linking really safe? What's the evidence that it works for a long period of time? Because after all, your collagen tissue may turn over. So this is the center where I did my corneal fellowship and where Dr. John Gallis is currently at. And so the 10-year data from this center, because it's one of the first randomized multi-center clinic that was enrolling patients pre-FDA for corneal cross-linking. And after 10 years, where they obviously every year you're going to get less and less patients returning to your clinic, and that's just sort of way of life. But if they looked at 30 eyes in these patients, 15 keratoconus and 15 ectasia patients, you could see majority of them after 10 years are still very stable, whether by topography or whether by their best corrective vision. And even using ABCD, which is the graphs, the 3 graphs there, you could see that in keratoconus patient, if they just use ABCD and reset the baseline, 93% of patients are stable. And if you go to the next slide where the ABCD is, they even add a new confidence interval for importing new patient database that have been cross-linked to allow you to actually better follow patients after cross-linking to see if there's any signs of progression, which is very useful. So we're not going to stop there with cross-linking. If we go to the next slide, so some questions that I get is, oh, well, you did some of the original research with other specialists and other centers, so you're favoring epi-off. Well, not at all, because I'm now very lucky to be part of the team that had actually joining this team that had completed an epi-on study in phase 3 that we're targeting, FDA submission. And so the question had not really been like, are they competition? Are they competing with each other? But that there's some literature data out there, actually quite a bit of them, showing that the efficacy of epi-on cross-linking could be better. And maybe it's not close enough to what epi-off has been providing us. And so by adjusting, remember I showed you that very first slide on corneal cross-linking saying that, hey, removing the epithelium allows more oxygen, allows more riboflavin to diffuse through, allows even more light energy to pass through. So how can we maximize that? Well, now we're trying to figure out a different way of delivering epi-on cross-linking to make it even more effective than the previous epi-on by maximizing the oxygen potential, using light pulses to allow oxygen to be consumed at a slower rate, as well as allowing oxygen to replenish itself, and then using different enhancers in the formula of the riboflavin to allow better penetration of riboflavin. So that to me is very exciting, and we already had started working on what we're calling next generation, which would involve a completely different device than what you are imagining or have seen so far. So honestly, it's very exciting stuff coming down the pipeline from Glaukos. And then you may be thinking, well, then why don't I just wait for all these exciting treatments that you're talking about? My advice to you is don't wait. Again, think about the fact that what if this patient is your family member, your son, your daughter, they're getting worse. Shaw and all from Moorfields in UK show that the impact of COVID, where they actually extended the waiting period for patients waiting to get cross-linking, that within about 9 months to a year, most patients lost nearly 1 line of vision, and with all the keratometric indices getting worse. And that's where I think I had told you that looking at different topographic indices like the ISV, IHD, IVA, where when we were talking about ABCD, that can maybe sometimes give you some clue in terms of the risk factors of who's going to progress and who's not, who's more likely going to progress. So that those are things that I think are very useful to rely on. And so I think the key is quality of life. We had a very in-depth discussion at Academy of Optometry this past week. Had the fortune to moderate a Keratoconus roundtable where we talked a lot about anxiety level and depression that's hanging over these keratoconus patients, potentially because they perceive it as a chronic illness. So we need to think about how to maximize their quality of life and hopefully how to better detect them so that they are not being led down a rabbit hole of not knowing what's wrong with them, because I hear that a lot from keratoconus patients, and then being able to tell them how you could improve their visual related quality of life, but also what you could do for them to refer them for stabilization with cross-linking if they're progressing. So I think that altogether, if we utilize all the tools we have properly and appropriately in a timely manner, we can maximally improve patients' quality of life. Thanks.
Hey, Clark, this is Andy. You know, just really quick. I know we had this discussion the other day, but when you talk, I just want to, really harp on this. It is National World Keratoconus Day. Clark and I spend a lot of time, and I would advise you to as well, if you're interested in keratoconus, to go on some of the social media pages and check out what patients are saying about their disease and what they're impacted by and what their opinions are. Because, Clark and I just came across a post, well, what was it, 2 weeks ago even, of a patient on a keratoconus group page that was literally reaching out for help because he was suicidal because of his disease of keratoconus. And, this disease really affects people to their core. I mean, this really affects their everyday living, as we all know. But until you see it in black and white in front of your face like that, I mean, I've been doing this for, decades now, Clark as well, Bill as well. But stuff like that just stops you dead in your tracks. And, you say, holy cow, this is real, and we can make a big difference if we do what we know. And so I just want to thank you for pointing out that quality of life issue and that whole discussion you guys had, because it is real and we see it all the time.
Well, Andy and Clark, a ton of awesome information and very appropriate on today, World Keratoconus Day. I do have a bunch of questions. We'll try to field a few of them. I'm going to throw these questions out to both of you. You guys can divvy them up. And the first one is, let me just scroll down here. If I'm treating a patient with Ortho-K, can I still use the BAD display and the progression display for monitoring keratoconus?
Clark, why don't you jump in what you would do first, then I'll jump in what I would say.
So I'm sorry, I was about to push it on to you. What did you say, Andy?
Oh, I would, okay, so if I'm going to get right to it, if you're doing Ortho-K, you need to keep that patient out of your contacts for quite some time, at least a week to reevaluate. And I would tell you that this is especially true with patients that, Ortho-K is very hot right now with myopia management. And, a lot of these patients, if you think about what a keratocone acts like, it's an increasing, it's usually a younger person. It's a person who has increasing myopia and decreased vision. And so what you don't want to do is mistaken your myopia management patients for actual keratocone patients. For those that are in Ortho-K, get them out of their lenses, let the cornea relax out for at least a week and recheck them. I would also tell you that using the Pentacam is probably a very wise device to choose as a primary, initial evaluation device. Clark?
And able to also in different models such as the XL, able to give you an axial length measurement, which I think is very very valuable to have as a baseline if you're managing myopia control patients, because should they have refractive changes that doesn't make sense to you, you can at least look to see if it's possibly axial length related versus corneal related.
Agreed. Oh, and the other thing that I would add, and I don't know how much we harped on it in the presentation, for your younger patients, and when I say younger, really younger than 20 years old, if you suspect that they have keratoconus, they should not be coming back more than 6. You should be seeing them at 6-month intervals and maybe even 3-month intervals. because those kids can change very rapidly and they could lose a lot of vision very quickly.
Yeah, and to that point, Andy, I think one of the paper that you and I usually has cited in the past by Dr. Hafezi actually show waiting a year, because this was early on, 10 plus years ago, where we were forcing all clinical investigators to wait to document progression prior to treating patients. And they did a subgroup analysis with pediatric patients and show that 88% of patients, while they're waiting to collect signs and prove of progression, 88% of them within a year all got worse. And that's the reason you don't want to wait for a year. You may not even want to wait for 6 months pending their risk factors.
Agreed.
Clark, do you feel that hybrid contact lenses are underutilized in keratoconus as compared to scleral lenses?
I do. I think that we should not, and don't get me wrong, I love scleral lenses too, and I increasingly have patients are wearing scleral lenses more than before. But I do think that the key, and I actually we did a collected data on retrospectively on 329 eyes, showing trying to figure out an algorithm to say what lens should we start first with majority of the keratoconus patients, and it didn't seem to come out that the success rate was that much different if you, at least not significant, if you would have started with a corneal GP versus piggyback versus hybrid versus scleral. What actually really changed the success rate was having more than one design, so that if we looked at the lens number one that we fit patient, and that said that's about, I think, 76% of success rate, and then with a second lens choice that we're able to offer patient, those who have failed the first round, we quickly go to 95%. So it seems like it's not one lens that fits all. It's more the diversity of lens design that's able to troubleshoot, what patient has, did not do well with different lens design. We're able to offer something else. So I do think for that reason that hybrid lenses are underutilized, because I think every lens can be matched properly to patients' visual demand and their physical ability to insert and remove lenses. And so for those reasons, I think that we should try to be better stewards in terms of matching patients with different lenses and not just blindly go to one lens design.
The last question I'm going to ask, Clark, you might want to comment on this since you were involved in some of the studies, and particularly some of the really early studies of cross-linking that showed a 0% of progression afterwards. You want to comment a little bit about Kmax and zero false positives, and just kind of how cross-linking studies have evolved from the beginning to current?
In terms of how Kmax was utilized, or in terms of why there was 0% progressed at the beginning?
Why there was 0% of progressive in the first few studies?
Yeah. So like the very first study, which is virtually the only, well, that's not true. I've seen some new studies that said at 1 year, everybody is stable, but mostly, the very first Dresden protocol study that came out of Dresden University in Germany, they only looked at 22 or 23 eyes, so it was a very small sample, and they were looking at stability of patients a year out, which that is likely the reason that everybody stabilized, and even like about 70% of them had gotten some apical flattening or reversal in their keratoconus, if you want to look at it that way. So I think if if in a short period of time, if you have small enough sample, it's always easy to say, hey, 100% of patients stabilize. And that had been a little bit of the criticism with some of the early work on epi-on cross-linking, is that they didn't have enough long-term data. And if you just look at 6 months, 1 year, it's very easy to say, hey, it's still working. And so that is the reason why I presented that 10-year data, because whether it's the new Glaukos epi-on that hopefully be approved very soon in the future, so that we can, have access to that within United States, but, a more newly improved epi-on, that was one of the hill that we were trying to climb, is that, okay, with some of the criticism from epi-on, how do we make that better? How do we maximize all the ingredients that could come together and give us longer efficacy over longer duration of time? And therefore, Kmax then can become a very important tool where you can at least have something objective, because at the very least, if you're comparing, say, vision, which is what we usually rely on as contact lens specialists, right? Like, we think of progression in keratoconus as, in the term where if patient had reported that they have lost vision or have issue with their contact lenses or glasses. But there are patients who could be losing vision while the cornea doesn't change. And that is the reason why keratometry is much more objective, and Kmax is at least compared to your BCVA, UCVA, or manifest refraction, your Kmax is a much more reliable metric to follow, given as long as you understand about the variability and the noises that you can get from exam to exam.
Great, Clark. And I want to thank Clark and Andy both. Again, always a wealth of information. I think I speak on behalf of both of you, saying to all our attendees tonight that for National Keratoconus Day, World Keratoconus Day today, I encourage everyone to look for keratoconus before keratoconus finds you. The old paradigm of waiting till patients can't refract to 20/20 is no longer acceptable. So again, even if you don't own the technology to screen these patients, work with someone who does. There's a lot. This technology is fairly prevalent out in the community, and get your kids screened just to be sure, particularly when there are risk factors such as siblings or parents with keratoconus. Again, thank you everyone for attending tonight, and we'll see you next time. Have a great evening.
Happy World Keratoconus Day, everyone.
Absolutely.